Welcome back to the Doc Talk podcast. I'm Dr. Sheila Wijaya-Singha.
And I'm Dr. Shazma Mithani.
Today's episode is for International Women's Day. And while this day is often about celebration of strength, leadership, and progress, it's an opportunity to look honestly at where gaps still exist.
So today we're talking about something harder. Today we're asking if women are still being gaslit by medicine. We'll look at what the data actually shows and what needs to change, especially here in Canada.
First, we want to take a moment to thank FIGS, our season sponsor. And honestly, this is an easy one for us, Shaz, because FIGS are what we actually wear to work. Their scrubs are comfortable, flattering, and genuinely cute. We get compliments on them all the time from our patients and colleagues. And they're also incredibly practical. The pockets actually fit what you need. Phones, notes, pens, everything. And in colder clinics and hospital hallways, the layers really do help keep you warm. Their compression socks are one of my favorite things. Supportive enough for long shifts, but still really cute and comfy. Same with their hair accessories, headbands, claw clips, and scrunchies that actually stay in place for our long shifts.
And their work bags are so thoughtfully designed with multiple compartments to hold everything from my stethoscope and gear to power-up snacks and a change of clothes. And if you don't work in healthcare, FIGS loungewear is incredible. They're thick, soft, and high quality. I actually got my husband a set and he lives in it. If you work in healthcare or you're shopping for someone who does, FIGS just makes sense. Go to wearfigs.com and use code FIGSDocTalk, that's FIGSDOCTALK, to get 20% off your first order. That's wearfigs.com, code FIGSDocTalk. So before we dive in, we want to acknowledge that not all women's experiences are the same. In Canada, Indigenous people experience unfair treatment or discrimination from healthcare professionals at notably high rates. And among Indigenous women, this can translate into their health concerns being minimized or dismissed.
We also see disparities for racialized women. For example, studies in Canada have documented that there's higher preterm birth rates among Black birthing individuals compared with their white peers.
So today we're exploring not just whether women are being listened to, but whether the system is set up to listen equally to all women, including Black, Indigenous, and gender diverse individuals. Okay, so let's start with the numbers first. We've talked about a few of these before, Sheila, but I think just laying out the numbers is really going to set the stage for this episode really well. So cardiovascular disease is among the leading cause of premature death in women in Canada. And about 1 in 3 women in Canada will die from heart disease or stroke. However, women under 55 still are significantly at more risk than men to be misdiagnosed after a heart attack. Some large international studies suggest that women are up to 50% more likely to receive an initial misdiagnosis after an acute heart attack. And we do actually have an episode specifically on heart health in women in particular. It's from season 1, but we just re-released it recently for Heart Month in February as well.
It's one of our most popular episodes, Shaz, and I think it really speaks to when we actually posted recently on a beautiful listener email that came to us about how listening to the episode helped her advocate for herself because she was dismissed when she went in, and it really highlights to us like why we do this work is to be able to help you as patients navigate the system because unfortunately we can be dismissed. Mm-hmm. So in addition to heart disease diagnosis delays, we also know that women experience delays in chronic diseases. And there are many chronic diseases that affect women disproportionately. Specifically, we know autoimmune conditions, so rheumatologic conditions like rheumatoid arthritis and otherwise, they disproportionately affect women. And women account for roughly 75 to 80% of those diagnoses of those conditions. But often they will report that they've had years of symptoms before an actual diagnosis. Another one that's very commonly delayed in diagnosis is endometriosis, so the chronic pelvic pain, the heavy menstrual cycles. And the average time to diagnosis of endometriosis in Canada is 7 to 10 years from the onset of their symptoms. So imagine like 7 to 10 years of suffering through those symptoms. And because of that, we're actually dedicating an entire episode to endometriosis that we'll be releasing soon so you can advocate for yourself to get the care that you need.
And when it comes to pain in particular, studies have shown that women presenting in pain in emergency settings, so coming to see me and my colleagues, are much more likely than men to receive sedatives, so things that are going to quote unquote calm them down rather than analgesics or pain medications. And in some studies, I know it enrages me too. And in some studies, it shows as well that women wait longer for pain medication. In Canada, maternal mortality remains rare overall, but Indigenous women experience much higher rates of severe maternal morbidity compared to non-Indigenous women in Canada as well.
And these are not isolated stories, Shaz. Like these are patterns that we're seeing. And when we talk about medical gaslighting, what we mean is this, like it's that your symptoms are being minimized or dismissed. often sometimes it's portrayed as like a dramatic confrontation of being dismissed, but what it really is that feeling that when you leave the room or you leave a hospital setting, that you don't feel like your needs were addressed in any way. They weren't fully explored. Your symptoms were kind of explained away for something often psychological, like you said, Shaz, before. Often saying things like, you're probably just stressed. And that's really unfair. And that's what we mean by medical gaslighting. And, certainly it's often unintentional, but the impact is really, really what matters.
Of course. And I mean, we've talked about this on the show a lot. And by now our listeners hopefully know that our main goal, like you and I, is to do the best we can for our patients. But like you said, the impact matters more than the intent, especially when we are faced with so many system challenges as well, which we're going to get into too.
So let's get into a little bit of background as to like, why are we excluded from healthcare spaces and dismissed more often? And we really have to start with also looking at research, like medical research in particular. Until 1993 in the United States, women were routinely excluded from many clinical trials, and that influenced global clinical trials as well. Even today, we know that sex-specific analyses are not consistently reported across the board when it comes to looking at medication research, heart disease research, or many chronic disease research as well. While we make up over 50% of the population, women's health topics make up 7% of research funding in Canada at this time.
Which is wild when you think about that, right? And this has really a lot of implications on what modern medicine was built on. It was built using male physiology as the default. And so for decades, we built dosing, diagnostic criteria, even the classic symptom descriptions around male physiology. We know that women present differently, and they don't always fit that textbook of what we learn in medical school and residency. And if you don't fit the textbook, you're being overlooked. Thankfully, we are correcting that by raising awareness around this, and we're starting to see equitable inclusion of women in research studies. But if you think about how long research takes, this correction is going to take time.
And then let's layer on actual system pressures in our Canadian healthcare system. It's like real life in Canada right now looks very stressed and stretched out, right? So we have 10 to 15 minutes with your family doctor. We have over 6 million Canadians who don't have a family doctor. There's long wait lists to see specialist colleagues. And in that kind of system where there's so much strain, understanding the nuance, understanding that we may not fit into that textbook, it's really hard to delve into that further when we have those time constraints.
And then when you look at things from an emergency department standpoint, all the emergency departments across the country are operating either at or above capacity with ballooning wait times, ongoing pressures within the hospital system as well. And so when we are in systems that reward speed, like you kind of touched on, Sheila, that complexity and nuance are what suffer.
Yeah. And again, it goes back to a lot of the conditions that we're describing, like endometriosis, autoimmune conditions. Those are complex medical conditions that do take time to understand and really tease out what's happening. Perimenopause is the other one that I really focus on, and that's a big one, Shaz. Like we've talked about it's not always clear, but it's a clinical diagnosis, which means that it takes time to talk to our patients and really understand what they're experiencing. And these conditions often don't present as one lab value; they present as patterns over time.
And then when you layer on top of that the cognitive bias,
so many layers.
So many layers, right?
Yeah.
So, anchoring, you see someone that has a specific symptom and you anchor to a diagnosis right away, or premature closure, which means that, you think you have this diagnosis and you don't think any further than that. We know that from the communication research, physicians interrupt patients on average within seconds of them starting to speak. So some studies actually show that the median time to interruption is under 20 seconds, if you can believe that. I mean, I certainly feel this pressure in the emergency department when I have so many other patients to see, when I have a waiting room of 50 to 100 patients. So I, in particular, really have to be deliberate about not interrupting and just making sure that I'm taking the time to listen to the patient, because that's often where the subtle little hints come in on what is actually going on.
Yeah, absolutely. Can you give us an example from the Emerge, Shaz, of how you navigate that?
So it's really just I have to deliberately tell myself when I walk into a room, if I know that I have 10 patients on the list to see, there are 55 people in the waiting room, I will take time to look at the patient's chart before I go into the room, and then literally talk to myself mentally and say, okay, you're going to walk into this room and you're going to listen to everything this patient has to say and really try to bite your tongue and not interrupt, because even though there's all these pressures of what's on the outside behind that curtain, I always try to, we've talked about this before. I always try to go one patient at a time and like look at the patient that's in front of me and focus on that in that moment so that I'm not missing things. And like truly, when we think about things from like a medical learner standpoint, if there are any learners that are listening, the investment on time up front is actually going to be much more efficient throughout the rest of your shift later because you're not going to have to go back and double check things. So like put that investment in time up front, because that's not only going to help you like find that nuance, it's actually going to save you time later as well. And that took some time, like as as a seasoned doctor now, for me to learn that and appreciate that too.
I appreciate that. It's one of the benefits of being a family doctor is I know my patients really well. I've known some of them for almost 20 years, and so I know their patterns as well. But even that being said, there are the pressures within family medicine to see our patients quickly. So it is taking that pause to be like, what else is happening here? And taking that moment to help navigate. But it is a real stress that can happen for us.
So I want to give an example from like a common thing that I see in the ER, and I want to hear from you, Sheila, too. We've talked a lot about heart health on this show, on the podcast, but it is still such a common misdiagnosis in women in particular in the ER. I can't tell you how many women I've had come in with like quite vague symptoms that end up being a heart attack. So I'm actually quite liberal with my cardiac workups on women who come in with like vague symptoms like fatigue or something doesn't feel right, because I know from experience and then also in looking at the research on heart health in women that it could actually be something serious.
Yeah, Shaz, I really appreciate that you have this ability to sort of make sure that you're casting a wide net when you're seeing women. And I imagine that's based on experience of seeing women being dismissed and then actually looking and saying, this could be your heart. We're just going to make sure. Right. So I appreciate that so much that you take that extra time.
And like, Sheila, you and I talked about this offline a little bit. There's actually a lot of data that shows that female providers are superior. And so Sheila and I are committing for season 3 to do an episode specifically on this, to like look at the research and the data to show the differences between, it's a bit controversial, but between female providers and male providers, because there is actually hard data that shows that. So we're going to put a pin in that, but we promise that we're going to have an episode on that in the future.
Yeah. Why do I run out of Kleenex boxes in my office faster than my male colleagues? Like
exactly.
There's different reasons for that. I think it'll be a really interesting episode. I see this in family medicine as well, in terms of like the longitudinal effect, where I get to my patients, I'm hopefully a trusted space for them. And so when they've seen specialists or they've gone elsewhere for care as well, they come to me, they're sort of like, I've been told everything looks normal. Like, I know that something's not right. And that's something that I think women are often dismissed in healthcare settings so much that becomes the internal voice that we carry. And so we normalize feeling abnormal, and that becomes our new normal. And that's really unfair. And I see like women in their 40s, especially, who are told that their night sweats and brain fog are just normal. They just need to go and have a glass of wine and go to bed. But when we actually slow down and think about the impact that this is having on their lives, the pattern was very clear for these individuals that this is perimenopause, or their thyroid is abnormal, and we just need to do some extra tests to do that. And we can actually come to a diagnosis, but we just need to take a couple of extra minutes to delve in.
Okay, let's add some more layers here because there are so many.
Oh boy.
Let's talk
We're
about
also
trust.
going to be hopeful. We are going to tell you the tips at the end here to make sure that you can advocate for yourself.
But I think it's also important for listeners to understand that this is so multifactorial and there isn't just one fix to this, right? And so let's talk about trust and the fracture of trust. And this is where it becomes a systems issue, where women repeatedly feel dismissed, that trust continues to erode. And when trust erodes, people look elsewhere for information.
Yeah, and that's no fault of our patients, right? Because you're looking for answers. And certainly we see this in Canada, where we're seeing a growth in private clinics. In my work, I'm seeing a lot of private menopause clinics, private hormone testing panels, executive health programs, longevity medicine programs, very costly. And then we also are seeing the rise of misinformation on social media, which we are having an episode on this specifically because it's such a public health issue.
And we are actually seeing a rise in what I like to call two-tiered drift here in Canada. And so when those who can pay out of pocket, they can get access to longer visits, broader testing, and perceived validation, while others remain compressed in the public systems. So private healthcare spending in Canada already accounts for roughly 30% of total healthcare expenditures. And that proportion has actually gradually been rising over time.
And also when trust erodes in the public system, the private market does fill the gap, like we've mentioned here, but it takes away the impetus from governments to actually fund the gaps that are in our public healthcare system, and then the inequity grows.
So now I want to get into like what tools we can give our listeners here to advocate for themselves, because it's important to advocate for yourself without blame. So we do want to be clear here, though. This is not, I mean, this shouldn't be happening, to be clear. Like in an ideal system, every person is listened to without having to, jump through hoops or navigate things in a specific way in order to be heard. You should not need a strategy to be heard, but until systems evolve and catch up, here are some tools that you can use to make sure that you are getting the care that you need and deserve.
And I want to mention, I start this process and I tell kids in my practice that this is what you need to do. And I actually speak to young children, age 3, 4, 5. We're starting to have these conversations on how can they use their voice in healthcare settings, because they may be dismissed if they don't know to use their own voice as a tool. And so it starts at a young age. I encourage any of you with young people in your life, like encourage them in these visits to do these things as well. So first off, I think it's really important to track your symptoms. Again, we have maybe 10 or 15 minutes in the appointment. We want to know clearly medicine's detective work. So if you can track your symptoms ahead of time, tell us how they affect your function so that we know the impact it's having in your life. That'll help us do our job in a much more efficient way and make sure we're addressing all your needs. It's important for you as a patient to know what your rights are, and you have a right to ask, like, what are the diagnoses that are being considered right now? Often, like you mentioned, there are biases, Chaz, that we have, our cognitive biases as healthcare clinicians. And we want to make sure as a patient saying, like, what are you thinking, doctor? What are you thinking to your nurse practitioner beyond just this is a thyroid issue or this is my heart? What else could be considered here in this situation? Also ask, like, what would change the plan? So is there anything that would change the course of our investigations? What do we do next in terms of, okay, we've done X, Y, and Z. Once that's done, what's next in our plan? So we always want a clear follow-up plan in place. And that's actually a part that often what gets missed. I'm sure you see this, Shaz, too. People come back into the emergency room after being admitted to hospital because they didn't have a clear follow-up plan as to what were the next steps. That is very true also in family practice. People come to me and they're like, I don't remember what was said. I don't understand. So always clarify follow-up. And a very important point that you made early on, Shaz, is that the healthcare setting is not a safe place for many of our patients, unfortunately, because they have a history of trauma. They have been poorly treated in our healthcare system. And so I always emphasize it's really important to consider bringing an ally with you to your appointments, to the hospital, to emergency visits, or when you are being discharged from the hospital as well. Make sure that someone's there who's able to listen and be of a support. If you don't have that, hospitals do have support individuals or ombudsmen or social workers that could also be a support as well. And finally, it's a bit of a long-winded answer here, but if your symptoms persist or evolve, and this is part of your I know this is your return to care plan, Shaz, that you do very well and they emerge, it's important to seek reassessment. You have a right to seek care. Don't just live with suffering of like, oh, they told me that everything's normal. Please do seek care if you are still having symptoms, because we need to look into that for you.
Okay, so let's talk about what actually needs to change. And there are a few different levels and layers here, but let's start with the actual clinician level. So if we have clinicians who are listening here, it's important to validate before interpreting. Avoid premature psychologizing, because we know that women tend to be dismissed into like, it's all in your head or you're tired or whatever. So avoid that. Communicate uncertainty. And I think this is a really important one, because I think that there's a lot of trust that is built in medicine by saying that we don't know, that we're not sure, that we want to do more tests or that we need more time. Those are things that are actually trust building, and not only are trust building, but then actually are able to effectively communicate to your patients that you don't actually know the answer yet, but that you're committing to doing more tests or more follow-up or whatever is needed to get the patient the care that they need and they deserve. So even saying something like, this is what I think it is, here's when I would worry, that reduces anxiety and builds trust. And in the emerge in particular, like my job, I always say to patients, because I often don't get answers in the ER. My job in the ER is to rule out life-threatening things. And so I can often go into, a patient that has chest pain or a patient that has abdominal pain and say, well, I know that it's not this, or this, because here are all the tests that I've done. I don't know what it is, but here are the things that you should watch out for. And here's when I would worry. And here's the follow-up that you should have. So that often reduces anxiety and also goes further into building that trust too.
I love that. I think that's so beautiful and helpful for our learners to know that. And again, being a family doctor, because I have this intimate relationship with my patients over many years, I always say that too. I said, I'm not holding back something. If I'm worried about this, I'm going to tell you. And when I am worried, I'm going to tell you. And when I'm not worried, I'm also going to tell you the truth.
Exactly.
Like I'm not withholding information. And one other thing I also say to learners is, listen, like always ask your patients, like, what do I need to know about you to offer you the best kind of care? Like, is there something that I need to do to make you more comfortable? Is there a history that you've had that has been uncomfortable in healthcare settings? That also helps really set a nice stage of closeness and trust that will also help your patients along the way.
Mm-hmm.
So briefly at the system level, Shaz, if we had a magic wand of like all the things that we wanted to fix, I feel like we could do some good work here. We need to increase research into female predominant diseases. We need to also make sure that sex-based analysis is mandatory in trials. We need to support longer visits for complex care through funding models that are how family doctors and specialists are paid. We need to address primary care shortages. Like this is something that you and I talk about regularly. Like we know you see it directly when people don't have family doctors, the impact it has on their long-term health. And we need to track diagnostic delays. When people are not being diagnosed, when they are being dismissed, we need to track that so we understand, so we can actually intervene because measurement drives improvement.
And then at a broader cultural level, we also need to normalize uncertainty, like I kind of touched on. We need to stop equating emotional expression with psychiatric cause, like that anchoring piece.
Hysteria.
Yes, that word, right? That should just not be in the dictionary anymore. We need to stop equating calm presentation with low risk. I mean, women often are, contrary to the like hysteria type, rhetoric, women often actually present calmly, and providers or healthcare professionals often will anchor onto that and think, oh, well, if they're so calm, then it can't be anything bad. But we can't equate those two things. And it's important to teach that cognitive bias explicitly in medical training to avoid the future generation of healthcare professionals to have these same pitfalls.
So this whole conversation for International Women's Day is not about turning patients against doctors. I do believe that most clinicians do care deeply for our patients, but caring is not enough if systems are misaligned.
Yeah, and I think that's a really important point because I do believe strongly, and I see that with my colleagues as well, that we always just want to do the best thing for our patients. But we talked about how many different layers there are that are preventing us from doing the best thing that we can. I mean, if women are walking out of appointments feeling unheard, that's not just a communication problem. It's clearly a systems design problem as well.
Yeah, and International Women's Day shouldn't just celebrate women's resilience.
It should change the systems that require it.
Thank you to everyone for tuning in to the Doc Talk podcast. A reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your healthcare provider for questions related to your personal health needs.
And of course, make sure to follow us on social media at the Doc Talk Pod, and be sure to like, subscribe, and review us wherever you get your podcasts.